It's very interesting, since I started doing laterals, basically when I learned from Dr. Pimenta back in, I don't know, I was not the first ones doing laterals in terms of adoption. I was in 2006, 7, I started, and obviously I learned everything from Dr. Pimenta, Dr. Bill Taylor, Bill Smith, all my mentors, and which is very interesting is that we start doing transoas, lateral. I learned the technique as, described and popularized by Dr. Pimenta. And then, obviously, for many reasons that you guys know, the outcomes were not reproducible at every level. So then all these variants start coming that distracted, I would say, in my own opinion, the procedure, in front of the psoas, all these other things that sometimes is the reflection of limitations on access to technology, and then you as a surgeon adapt, trying to adjust your outcomes, So anyway, but independently of everything, we've been doing lateral because, you're placing the patient on lateral, and then you do the surgery on lateral. You do the A-lift in supine position because you put the case from the front. You put the screws on the back, and then you put the patient on prone. So that's like, I will say, you do an ACDF, you do it from the front, And I will say that's the natural routes of the different approach that we do. But when time and money and comes into the picture, you try to modify things. And this is very interesting on the approach. The approach has been modified. So right now, for example, you do laterals on lateral, you do laterals on prone, you do pedicle screws on lateral, you do, someone is going to show up doing an A-lift on prone, who knows, But it's very interesting. That's what I like what we do, Every time we're trying to find a more efficient way and a better to flow. So now I'm going to talk about a little bit of prone lateral. And obviously, as always comes, and it's something that Pimenta, I learned a lot from Pimenta, every time something comes different, you have everybody start asking you why. You're already doing something good. Why are you going to make me uncomfortable, So I'm going to try to show you what I think, what are the benefits of prone lateral, and then a little bit of techniques. And obviously, Dr. Pimenta will show in the lab the full-blown technique that it will be easier to comprehend. So the first question is, as I told you, everybody asks, who faced the benefits doing prone position, doing lateral in prone position? So I'm going to start with a very funny story. So we have this meeting at we call the snow meeting for international audience. Every time around January in winter time in America, there is 3 or 4 or 5 meetings that are done in, ski resorts area, and we call the ski meetings. So one of them, which is amazing, is usually has been chaired by Dr. Lenke and Dr. Regis Hayes, and he's been changing through the years. So when they invited me 16 years ago, they invite me to present our deformity using the MIS lateral and all the lateral approaches. And I presented, and I remember Dr. Lenke came and after my talk, and he said, Juan, I like it, it's very interesting. I think this is a good future in this. But then he just asked me, Juan, why you guys don't do this thing in prone? You may have more lordosis. I was like, this guy is crazy. I was like, how can you do lateral in prone? If it's already hard in lateral, I can imagine in prone. But anyway, now we're doing it. So what I'm trying to tell you is it's amazing how visionary is Dr. Lenke. He's someone that is ahead of us. Just think on Elon Musk, all these people. Even Dr. Pimenta, these people that are ahead of us, We just guys reproducing. We just like the how would you say that? The Kaboom guy, you remember on the Billy May? Just like we're great guys, moving things. But this group of people are amazing, They actually ahead of our generation, I would say. And then prone lateral, actually, when I do a prone lateral right now and say, wow, in some situation it's amazing. So we go to the question, who faces the benefits. I like to show a lot of pictures, less text on my talk, so it's easy to go through it. So basically, it's why could you save time and money? I mean, there is something better than time and money in life. That's what the main goal, you know. The more time you have in your hands, the more time you have for a million things, you know. You can go and play golf, stay with your girlfriend, have time to your family, who knows? Time is amazing. So whatever you show me that I can save time, I'm on it, you know. And also, obviously, whatever save money. So for the health system, if you do a surgery faster and more efficient, it goes good with the health system. It's a less expensive system. Anesthesia, they love prone position on the spine. Why? Because we've been doing prone surgery since day one. First surgery a spine surgeon learned is to do what? One of the fellows, a laminectomy, correct? How you do laminectomy? Prone. You know, everything that you start doing in spine is prone. So it's a very familiar approach with us. So when you think about patient on a spine, you think about someone in prone position, and you just had that because that's the way that we were trained. So actually, that's very good. But then, who is good for prone lateral? To me, the best example is a bag of golf clubs. You know, prone lateral is one more club in your bag. So it's not for everything, but when you can use it, it works very efficient. So that's the first thing. I don't think the prone lateral is actually a procedure that's going to take over everything on lateral. It's just going to be a great surgery for some specific application, and that's what we're going to see. And, you know, obviously, as the time goes, the technique is going to get more refined, and we're going to expand it more. Remember when we started doing lateral, Dr. Pimenta, when they started, he was doing 2-3 level lumbars. Suddenly we start doing thoracolumbar area, and then we get into thoracic, and then the corpectomies, and then you name it, yeah? So prone lateral is I would say, we're just trying to understand what is the nature of that. So this is, I'm going to put in here in these two little squares, what I think advantages of prone lateral, what are these advantages up to date. In 1 year, I want to bring exactly this slide, and we see what we can take out and when we can actually put in addition. So advantages, okay, pedicle screw placement, amazing on prone lateral, yeah? I mean, when I do single position lateral, I struggle putting those screws, you know, especially the lower ones. Oh my gosh, you know. So you're a guy that like to take shortcuts and only use unilateral screws. I mean, that's your deal, you know. But if you really want to do it bilateral pedicle screws, the best biomechanical structure, nothing better than prone, yeah. Okay, another one. You want to do a laminectomy, you want to do a direct decompression. In some cases that you have to do it. Remember what we learned also from, you know, our lateral experience. When you have facets that are impossible to do in direct decompression, when you have huge synovial cysts that they just cannot do it, what is the best way to do a laminectomy? Prone. So it's amazing, yeah? Then second, easily patient position and taping. You know, prone position in surgery is a very natural position. You just put the patient in a Jackson frame, any, you know, OSI table, patient goes almost straight forward on the perfect AP position. Do it on lateral. You see how much we always say when we do lateral surgery, on lateral position, 60% of the surgery is position, 40% actually the surgery. So and lateral position is a very unstable position. Patients likes to cork a little bit on you. So that little detail is too much against one factor that we're having right now, which is the navigation and the new enabling technologies. So lateral navigation is not as good as prone in navigation. Then the other one, obviously, when you put a patient in a well-positioned in a Jackson frame, the lordosis potentially is better than when you have it on lateral. So this could be advantages. And then, obviously, robotics and navigation love prone position. Why? Because the less the patient moves, the more stable is, the better the navigation works. Again, think on lateral. Patients cork and cork. You lose your reference marks, you're done. Navigation is out. Welcome to the world of new complications. Yeah, but there is disadvantages, what I think. And then obviously, when you don't prone, the peritoneals move, contents may move anterior. And then this is gonna show you later on, the psoas seems like a migrate a little bit posterior, which may have some benefits. Okay, disadvantages, ergonomics, you know, I mean, I mean, we like animals, whatever you tell me to do and I do it 100 times, then I like it and then I don't feel comfortable doing the other way. As per today, I think it's more comfortable to do the lateral on lateral position when you're standing behind that you did on sitting position or putting the patient this high on that, looks awkward. So ergonomics has disadvantages, okay? Obviously, manage the table. I mean, you can have whatever you want to break the table on prone. Nothing breaks better the prone than when you put it on lateral. You just have the gravity working for you. The jackknife is amazing. The body is made to break when you bend lateral by being on lateral position, yeah? So that can be a problem, especially when you're dealing with the lower levels, 4-5, or on the thoracolumbar junction. So moving the ribs up, which is a big, so I always say you break the table on lateral, more than moving 4-5 out, is actually moving the diaphragm up. So you can access L1, L2, and L2, L3 always on the retroperitoneum, never moving ribs and all these things that some people do. It that doesn't make sense to me. And then this is a counterintuitive approach, as I mentioned before, You're doing lateral in prone. You're doing, it's like when you do, pedicle screws from the lateral, or when you do the A-lift on lateral position, it's a little bit counterintuitive. And then, obviously, this is the last one that we mentioned. I mean, you tell me, Rod, maybe you're going to be the first one. Pimenta is going to come next year doing an A-lift from the prone position. Who knows, with some mirrors, on endoscope. I bet that someone is going to come with that, And whatever comes with that, I promise you, I'm very good popularizing things. Show me the way, I'll make it happen. I'm not smart enough to put it together, the project. So Pimenta, put it together, and maybe we just go from there. I don't know, some cameras. I'm sure the technology is so fascinating right now that you can do almost everything, yeah? Okay, so I'm gonna do a little bit of preview of this one. This paper, you just submitting the abstracts. Finally, we get all the data together. So what we did in here is we get voluntary people, and we collected finally we get this research funding in our institution, which is expensive because each voluntary person spends more than 1 hour on the coil, on the MRI, trying to get all this position, prone lateral, prone lateral with the hip flex, hips extended, supine. So we did like 6 different positions. And the only reason is we're trying to find out what happened, not only with the psoas, but also with the intraperitoneal structure. So I'm going to give you a little bit of the preview. This table is complicated. I put it on black and white, so you guys don't even try to read it, But I just think I wanted to put it because the point is this one, okay? So when you have the patient, this is the psoas moving from anterior to posterior, okay? When the patient is lateral in position with the hip flex, the psoas is more anterior with the lateral with the legs extended. When you have prone flex the legs, like when you put on the OSI table with the sling, it tends to be more anterior. And then supine and prone, which is very interesting, this is when the muscle is more posterior. And probably is related because when you're in supine or prone, your legs are extended. And then that one migrates a little bit the psoas posterior. This is good because we are assuming that the femoral nerve, that is the most horrendous complication on the lateral surgery in terms of the nerve injuries, is usually inside the psoas. It will migrate with the muscle back. So it can give you a little bit of a landscape to get there, yeah? And then obviously the muscle also has changes on the shape. And this is something that we measure, the three-dimensionality shape of the psoas. So actually when you are extended the legs, the psoas tends to be a little more flat, which makes sense. It's under some traction. There's a little bit of pictures, but if you're looking here, lateral flexion, you make a line in here, you see how the muscle moves more anterior in lateral that actually when you're in prone. You see in prone, actually the muscle is more posterior. So that way, the plexus is right here, yeah? It moves a little bit more posterior. That makes you a little better the entrance. But this is a minor changes, but that will say. Okay, so I'm going to tell you another thing. This is basically a big takeaway message from the prone lateral. There is 2 unique things out of this surgery. Gravity is the king, as we know, You put the patient in prone, everything likes to move anterior. So the retractor moves anterior, so you have to be careful because you're gonna have more what we call unintentional ACRs. You're gonna be, again, you're gonna, be careful, you can have more vascular injuries, all these things, because everything moves anterior. And the second one is the retractor likes to kick out, it's like the retractor likes to go superficial, So what is your game? How can I keep my retractor posterior and deep? If you control these two things, then the surgery becomes more manageable. So this is what I say, the two fundamental factors of the prone lateral surgery compared to the lateral, So everything, the retractor likes to come out and likes to come anterior, so you have to control that. Why is that? Well, one is because the gravity moved the retractor down. The other one is when you are in prone position, these spaces are a little more relaxed, so the retractor is more loose, likes to come out, So let's see, for example, so I'm gonna show you two cases in here, and then we will finish the talk, and then Dr. Pimenta will show the demonstration. Okay, the first case that I'm gonna show you is a straightforward minor deformity that this is like, I would say this is the ideal case for lateral surgery and deformity. Patients that have 5'1" is not too bad. The scoliotic curvature is minor and is on the lower lumbar area. It's not a thoracolumbar. And the first case I'm gonna show you doing the surgery prone lateral with x-rays only, with fluoroscopy. The second case that I'm gonna show you is using what we call enhancing technologies, basically navigation and something else. And which is interesting is prone lateral loves navigation. If you really want to do prone lateral, you much better do it with navigation because it's amazing. I'm gonna show you here. You're gonna see in these two cases, the difference between doing it with x-rays and navigation, yeah? So, and the good thing is navigation is becoming now like a commodity. Every hospital, almost, at least in America, they have a navigation system. And this is just gonna get better, So let's see this case. So this is the patient, gap score, whatever you use to do that, make sure that you understand the principles of deformity. This patient, in the other words, didn't have the need for too much lordosis, so basically fits really good the bill for less invasive. So it was losing, 10, 15 degrees. So I was like, how can I do something in one of these levels? So you go back in here, this is the x-rays. You see it's a little bit of flat back, as you see here. This is a little deformity right here. And then this is the MRI, classic MRI of a deformity. And then you look at the CT, you have some olisthesis, which is interesting. When you look at the MRIs on patients like this, for the people that are new in lateral, they walk away, oh my God, how are you gonna do that lateral? Actually, no worries. By the time you put the patient on the table, it's on anesthesia, these levels start working with you. And then it has another interesting thing. This level, as you see here, 5, 4, 3, 2, 3, we were losing a lot of lordosis in here. So to me, when I see this level is a big opportunity to do an ACR or something that gives me some lordosis. So we put the patient in prone, obviously have good bone density. And then, okay, positioning can be tricky in prone lateral. Dr. Pimenta will expand there. If you have money and you can buy systems that crank the patient and all these things, that's good. But if not, if you're working in a regular hospital, somewhere in the world, you just need a Jackson frame table and you start taping the patient, the hips, the chest, put something contralateral, so acts as a pivot. You see here contralateral, I build this MacGyver type of a bolster, so I can go from the other side and the patient don't rebound too much. Okay, and then this is something that I recommend it to do everybody. You put the patient in prone, you make these 3 lines. One on the midline, you mark it with your fluoroscopy, one at 5 centimeters and the other one at 5 centimeters, and then you mark your level in here. Why? Because when I open the patient, I know if I go this direction, pointing to here, this is my level. And then at 5 centimeters, I put all the screws. No matter who you are, what you do, what size you are, what color, what race, 5 centimeters from the midline, you always find the pedicle right there. So to me, they're classic. And if you do that, trust me, your life is gonna be easier. You don't want this, you work with residents and that you work into a room and then the resident is very inspired that day and the back looks like a Picasso. They draw the vertebrae and this spinous process is crazy. But then, you end up doing the incision at 4 or 5.5. Trust me, 5 centimeters make the trick for everybody. So then you mark the patient, the fluoroscopy does the same. You open your incision, dissect through the muscles, get into the level. See, is that the level of the holisthesis? You find the way that you actually, you make the wire goes through the space, and then you dock your retractor. Then you start dilating, you put one implant, then you go finally to L1, L2. I want to see it. We did an ACR on that level using here. So that level that was almost flat and kyphotic, we put a 15 degrees cage. We grab it with screws, and then we get some decent lordosis, and then you put the screws on the navigation after that. So this is the way that you flow with fluoroscopy. With fluoroscopy, I do the lateral first, and then I put the screws, because, I don't really doing too much. Usually you see a little bit of navigation there because I was doing the screws with navigation, but not the lateral with navigation. And then you see here the pictures before and after. Obviously, is a really good correction of the lordosis. On the coronal, as always, the lateral works very good. This is the MRI immediate post-op. You see indirect decompression, very good, level by level. This level that was kyphotic, you see how nice is lordotic. So actually, it's a really good indication for lateral, this patient. And then you leave 5-1 alone, because the 5-1 alone was not too bad. It's a young patient. As we learned from Dr. Pimenta, try to stay away from 5-1 as much as possible, because the minute that you fuse the patient to the pelvis, you open the window for a brand new set of problems. Okay, then this is the final product. It's very good. Okay, now go in the nice one. This is like the nice case to show, because this is a case, everyday case, 4 or 5 patient that comes all the time. It's a million ways to do this patient. Some central stenosis, foraminal stenosis, classic. You see hyperintensities on the facets that is telling me up front, hey, I'm good for indirect decompression. So this patient has DCT. And then I like to show you here. See the little facet growing in here? It was not bad enough to stop the indirect decompression. Why? Because on the MRI, we have hyperintensities of the facet. And then these are the flexion extension, just for make sure that you guys don't think that I'm doing this surgery just because, the patient was moving on flexion extension. It wasn't stable. Okay, let's go a little more in details in here. Okay, again, positioning. Put the patient on the prone table. In this case, I'm using taping like crazy, I'm becoming like the best customer of 3M or whatever, make the tape. So you take the patient, you pull up and down, and then again, don't forget that. One line in the middle, 2 lines are 5 centimeters. And in this case, you see this little asterisk in here. This is where it goes, the reference mark of the navigation system, yeah? So at that 5 centimeter lines help me a lot. It gives me the line for my screws, the line for the reference mark on the iliac crest. It makes a lot, And then you take, watch this is a hybrid. I still take some x-rays and some clip parts of the procedure. Why? Because navigation is not bulletproof. Don't forget, navigation lose the accuracy, you're done. When you're gonna go, you're gonna be in really bad places, yeah? So I use the X-ray to keep me on form. So I do the spinning. Okay, so when I do this case with navigation, I change my flow. First thing that I do is I put the pedicle screws first. So, okay, the first question, why, Juan, you do the pedicle screws first? If, why don't you do the lateral? I say my answer is, when you need the navigation, the most accurate is to put a pedicle screw, The navigation for lateral, you're 2 millimeters off, who cares, It's you just you have a lot of room. But if you're 3 millimeters off, 2 millimeters off in a pedicle, it means you're in the canal or you're somebody else. So I start with the pedicle screws. And take a look at these screws. They are modular screws, okay? You guys are gonna ask me again, why modular screws, and why don't you drop the towers and everything right away? So I'm gonna give you 2 good answers. One is, first, obviously you don't want to drop the rods first. You still can leave the towers alone without the rods because you need indirect decompression. But the second one, which is very important on this approach, is when you're doing prone lateral and the patient has a big habitus, you are going to work deeper than normal. If you use blades 140, 150 on lateral. In prone lateral, it's not unusual to use 160, 170 blades. You're deeper, and your fingers are not enough to feel the psoas. So you get afraid that you can get the colon in your way out. So how do you prevent that? So watch this beautiful trick, okay? And hopefully you guys take it. So you mark the incision, you see here, I'm gonna use navigation, I'm still use X-ray to make sure that everything is fine, okay? You mark the incision, you open the incision, I already put the screws, modular, that is not the point in here. And remember these lines again? 5 centimeters, 5 centimeters, this little thing that is the marker, and this one was the target, yeah? So I'm going this way, into that, okay? So now, once I put the screws, then the point that comes is this, okay? So I'm gonna start moving some videos in here. You see that's the fellow right now putting the finger? That finger is going actually where I put the screws through the 5 centimeters incision, helping me to find my other finger into the retroperitoneum. Take a look where it is the psoas. So actually the classic 2 incisions approach that we used to teach on lateral, but now I will call it as an opportunistic access, because that 5 centimeters incision, I was using it for the screws. So you feel the TP, go around it, and then you feel your finger, there you go, you help to put the dilators. If you have the towers, it's hard to do it. That's why modular screws is beautiful on this part, you know? So that one is a big deal. So you get in here, so you put your finger on there and there. This was a big patient, so I was not able to feel with my finger the psoas. So the other hand was helping me to find the psoas, as you see here. And then watch this other trick that I have in here. Pay attention to this because this is very important. So you're gonna see, I get this navigation. See what I'm touching right on the midline? I put a 16 gauge needle on the spinous process, and I use it as a reference mark right there. You see there? I'm touching the top of the needle, make sure the navigation is accurate, yeah? So I'm gonna go in here with more details. You see, now start putting the first dilator. Another beautiful thing on the navigation and prone lateral, you pick what part of the psoas you getting through. Nothing, you never see that on X-rays, yeah? So I can see, you see right there, I'm trying to see where is my entry point on the psoas, yeah? So I'm picking up a point anterior on the psoas that I can get through it with no problem. You see there, I'm customizing, using navigation, having a full 3D-dimensional view. You see the screen on the right is telling me the up and down. The screen on the left is giving the axial view, anterior, posterior, and then the lower 2 X-ray images are the synthetic X-ray that help me out. And noticing here, I keep always the fluoroscopy in the AP position. Why? Because once in a while, I had to make sure that the things are not crazy, especially when I start dealing with the end plates. Okay, now we get here. You see, again, I was checking the accuracy of the navigation. Then now I have my finger on the psoas. I start passing the dilators, and then obviously start doing the monitoring. So prone lateral has to be, have 5 more minutes, how will be done? Prone lateral is very interesting because prone lateral is very hard to do pre-psoas. Some guys are putting on LinkedIn, whatever, that they do in olive in prone position. I think that's probably a misconception. They don't probably know better about the approach, but I don't know how can you go in front of the psoas in prone. You do that, do an A-lift, yeah? So using here, I do the monitoring, you know, which is the same. I can tell you, yes, the muscle moves a little more posterior, but get prepared. You still can have femoral nerve injuries. When I start doing prone laterals, I start pushing very hard this procedure, and I was doing transitional levels. Guess what? I had my first femoral nerve injury after like 40 years of not having on lateral, and it was a prone lateral case. I was lucky that the patient recovered after 6 weeks, you know, he got better, but nerve injuries happen, so don't guys take it for granted that because the muscle moves posterior, you will not see injuries anymore because you are gonna see it, you know. Same thing, timing and good retraction. Then using here, I check where I put my dilator with the fluoro. Even if in navigation I like where I am, one shot, tell me I'm in a good position, yeah? Because I don't want to take any advantage to have problems. And then just keep going using here. I'm already make sure that my entry point was good. Take a look on the screen of the navigation, how nice it looks now, exactly where I went through the muscle, make sure that I was not pulling that. And then the rest is basically where it's coming. You see, again, a little bit of nice screen. Take a look at the panel of the pictures. Floor on my right, navigation in the center, monitoring on the other one, and then less ray exposure on the other one. And then you keep going. Then obviously you see the ergonomic socks. You know, I'm sitting, moving my head sideways, trying to get there. Then that's the regular thing, carpentry. Put your instruments, get through it. And then in here, I make sure that there is nothing close to a nerve. So see, I'm stimulating, make sure that everything is good. Then carpentry, yeah? You put the cup, you see here in navigation, you can see, you have to be careful. Paul Park has a great experience on navigation and robotics on Lateral. He will explain you. The instrument looks a little bit funny on the navigation, especially the cups and that. So you have to make sure that, you know, you are where you are. That's why I like to still take one shot once in a while on the x-rays. And then you get in here, you put your box cutter, then you put your implant, and then the next is this one. You see the next part. You go to the 5 centimeters incision, capture the polyaxial heads. So now you finally put in the towers, as you see here. Then once you put the towers, then this is like a joke, put your rod, and then you drop your set screws, and then you're done, yeah? Okay, so just to finish, so single position surgery, we think it's safe and reproducible. It has a potential for saving some time and money, don't forget that. We need obviously more prospective trials. If you want to read about the details of the technique, we put already a paper with a really good video, step by step, everything, how we do it, and it's totally unbiased, you know, it's not attached to any company. Is trying and also trying to make it simple. You know, we don't want to make it like you have to buy brand new things to do it. You know, any system that you have lateral should be able to do prone lateral if the system is good. And then obviously you always can follow me, and for international audience, they always visiting opportunities, because we understand that if you spend time with me and you follow me for 1 week or something, I bet that your outcomes are going to be better on lateral. So you're welcome to email me, ask me through LinkedIn, to the social media. We have a full good international program at BNI, so we facilitate you guys to come and learn from these good techniques. Okay, thanks very much, and we're going towards